So we go on to our last set of talks by Dr. MAHIPAL SACHDEV, who heads the Center for Sight Group of Hospitals. And he's going to talk on a very important topic for all of us to know about understanding regression and ectasia. How would you differentiate them? So on to you.
Thank you very much, Dr. Chitra, for including me in your course. I'll be talking about regression and ectasia as to these are things that all of us deal with. And as we all know that refractive surgery can cause changes in the corneal shape and thickness, which can lead to two different types of conditions. So in both of them, what you will get is a person who is, say, a myope coming back to you with myopia. And how you can differentiate a regression and an ectasia. These are two different distinct identities, and the treatments are going to be different for both of them. To differentiate between regression and ectasia, what you need to do is a thorough eye examination. It's the same examination that you do as a pre-op for workup of a patient, because that will help you decide even if it is a regression or it's an ectasia and what you can plan to do for these particular things. So you need to do what is known as corneal topography, pachymetry, visual acuity test. You have to also do the epithelial mapping, etc. Now, corneal topography can reveal any irregularities. One main thing is that there is a standard central blue area that you get once you have done the ablation for a myopia. That is what you get in case of a regression. That is not changing. That is still there, and there is no irregularity or asymmetries that you can see in the corneal shape, which you would get when there is an impending ectasia that is happening, or there is an ectasia. And the pachymetry can measure the corneal thickness at various points. So therefore, you have to measure the corneal thickness. If there is an asymmetric area which is the thinnest or which is becoming the thinnest, then obviously you are dealing with an ectasia and you are not dealing with a regression. So just to briefly say as to what is the difference, there is in ectasia, it involves the progressive thinning and bulging of the cornea. That means it is a progressive thing that is going to happen till you intervene. Once you are having an ectasia, it is going to be there and it is going to progress, and at times in women, hormonal therapy or pregnancy can precipitate an ectasia very fast. So that is something that you have to understand. While in regression, a partial loss of the initial correction is achieved through LASIK surgery. Regression often can be early or late. So an early regression is not really a regression, that you have to say or put it as an undercorrection or an overcorrection. So that's basically you didn't get the effect. So if within the first day or first week or whatever you have, so that is essentially an undercorrection that you have. But if it comes later, then you call it as a regression. The symptoms of ectasia can include progressive visual distortion, increased myopia, astigmatism, and corneal steepening. And what is important is that if you are having an ectasia, this is usually not correctable by spectacles. That means that you do not tend to get 6/6 vision in these particular cases if you are going into ectasia. While when you are having a regression, it is just a refractive error that you are having as myopia, hyperopia, or astigmatism, and it is always correctable by spectacles, which is there. The ectasia complications typically occurs when the cornea becomes structurally weak. That means that what damage you have done or whatever you have done to the cornea is not able to withstand that, and it loses its shape after the removal of the corneal tissue that has happened, whether it be the LASIK flap or the smile cap and the tissue that has been removed. Regression can happen, in the contrary, can happen due to various factors. One doesn't know all of it, but that is a healing process, normal healing process, how the biomechanical strength of the tissue is changed, how a tissue behaves, and the process of cornea age-related changes in the eye or individual healing response. Now, characteristic topography is seen, which is similar to what you see in a cone. While in a regression, you see a central flattening of the cornea, which is there, which is again a significant topographic finding. And this is the incidence of post-LASIK ectasia. It is undetermined, as people can say, and it can vary. It has been reported the number or the incidence is going down because of the posterior float scanning and the bad, etc., the diagnostics that we have, which is there. What are the risk factors for ectasia? Would be keratoconus if you have operated, you have missed out, high myopia, low stromal bed thickness, excessive ablation, small zones that you do, form a fustic keratoconus, PMCD or other determinant. And this is something that has stood the test of time. This is the Randleman risk scoring which you have. This gives the risk scoring, and if there is 0 to 2, that is a low to moderate risk. That means that you have a normal topography, you have residual stromal bed which is more than 300 microns. Age is, the patient is of a higher age. Central corneal thickness is more than 510, and the dioptric correction is less than 8. So if you have this is a Randleman scoring that there is a moderate or no risk of ectasia which is there. However, no scoring even in thick corneas that you have, and even with low numbers you can end up with ectasia, and that still happens, and that obviously we still don't know what is the reason. For a diagnosis of ectasia or regression, again the evaluation of the posterior curvature, as it was important pre-operatively, is something which is important. And pre-operatively there is also something, though it is losing some amount of relevance, but the PTA should never be more than 40%. That is the percentage of tissue altered. So you are taking away tissue because of the flap and the ablation, and that should never be more than 40%, which is there. Relax smile or silk or what you have today is clear or ATOS, it's supposed to be giving better biomechanical stability. And there are some animal models which Reinstein has said that instead of keeping a 110 cap, you do it at 140 or 150, because it is the anterior stroma which contributes more to the strength of the cornea, but this is still to be taken on as something different. Red flags of refractive surgery are important. Pre-operative screening is something very important that you have to do vis-a-vis a case of ectasia to rule out or to see that you don't have. And these are some of the points which all of you know: asymmetric bow tie, skew more than 20 degrees, irregularity of between 3 and 5 millimeters of greater than 1.5 diopters, highest point 50 microns from the back sphere, and then peripheral thickness less than 20 microns, thicker than the central thickness, and thinnest reading greater than 30 microns, thinner than the central reading. Ectasia management, obviously I'll not go through the detail, but you have to seize the progression. And in my opinion, a corneal cross-linking alone does not work. You have to always supplement it with the intracorneal ring segment that you have. Then only you are going to stop the progression. So we do a simultaneous corneal cross-linking and we do an intracorneal ring segment. In regression, laser vision correction is safe and effective. But nowadays with the present OCT, you have to actually look at the thickness of the flap and the residual bed thickness. Earlier we used to lift the flap and then do a pachymetry. But now the OCT can pick it up and you need to know what is the flap, because especially in metal keratomes, there is a lot of standard deviation that you have. You can do a surface ablation if you have thick enough flap, or you can do an ablation by relifting the flap or recutting the flap. If you want, you can do a side cut, etc. And that is what you do in regression for the treatment. Epithelium needs to be studied as regards epithelium remodeling. If there is a lot of hyperplasia of the epithelium which is causing regression, it may be better to do a surface ablation rather than do this thing, remove the epithelium and then go ahead and do it. Regression causes, these are things which have been talked about: nuclear changes, cellular mediators, inflammation, etc., etc. Some people have tried anti-glaucoma medication, giving more steroids or mitomycin, but if a regression has to happen, it happens. I don't know how well these things happen, but just for sake of completion, which is there, that is there. So common guidelines before planning enhancement is that the refraction should be stable, tomography should be stable, it should not be an index myopia, and you have to look that there is no cataract that is setting in, and basis that you have to treat. And there is dry eye, you should treat that first. Flap relift versus surface ablation is something that is the jury is out, which we had a separate discussion. So to sum up, regression versus ectasia, to differentiate between regression and ectasia, a thorough eye examination is necessary, including corneal topography, pachymetry, and visual acuity test. Corneal topography can reveal any irregularities or asymmetries that are there in the corneal shape, while pachymetry can measure the corneal thickness at various points, and that is important for you to be able to understand whether you need to do an enhancement or not. And a significant thinning of the cornea, particularly in the central or paracentral region, may suggest the presence of ectasia. If ectasia is suspected, further testing may be necessary, such as topography, which can provide a more detailed analysis of the corneal shape and thickness, or a corneal biomechanical medical assessment which can evaluate the corneal resistance to deformation, and treatment ASAP is very important. The moment you smell an ectasia, it is going to progress. You should immediately intervene so that it does not cause a person irreparable visual harm and damage. And usually the results of cross-linking with intracorneal ring segments are good. Otherwise, you have to do a graft replacement surgery. So take-home message is regression refers to partial or complete reversal of the refractive effect of the surgery, while ectasia is a progressive thinning and weakening of the cornea that can cause visual distortion and other complications. Thorough eye examination, including topography, pachymetry, etc., is required. In the two conditions, you need to separate that out because the two treatments are separate, and good treatment initiated at good time can take care of a lot of these problems. Thank you very much for your kind attention. Thank
One
you.
question: if the patient has regression and it's come to you after many years after primary procedure, would you want to do a PRK for that eye, or would you ever consider lifting the flap?
Oh, I have lifted the flaps even 16 years later, but the point is that epithelial ingrowth can happen. You have to do the OCT to see what is the thickness. Chances of epithelial ingrowth are higher, but I normally put a glue and a bandage contact lens in these particular cases
And also, you could debride the epithelium a little distance beyond the flap
Yes, and
margin.
that's why you need to put glue. But the jury is out whether you want to do with the new surface ablation techniques and the flying spot. I think you can easily do a surface ablation if it's a small refractive error.
Yes.
It depends on the amount of refractive error. If it's a refractive error, you can even do an ICL subsequently. You can combine two different procedures. You need not do a corneal refractive procedure if already the cornea is flat and thin. Thank you.